Okay, you can get started.
Thank you. Good evening, all, and welcome to session number 2 of 7 from this latest series from the Hand Education Committee from AO North America. It is Thursday night in America, which means it is time for AO Hand Education. And much as we've done over the past 2 years, we strive to provide you with high-quality education for hand surgery as much as possible every Thursday. And it seems like it would be incomplete without covering complications in upper limb surgery. So this latest series, for those who may have missed the first session in this series, is dedicated to the bugbears that we face in our lives as hand surgeons, complications in upper limb surgery. The last series was on distal radius fractures, and this session is on tendon surgery. So most of us who take care of upper limb tendon injuries know that complications happen, and they can be quite a challenge to take care of. So with that being said, we have a moderator par excellence in Jay Bridgeman, who's going to conduct this session with his hand-chosen faculty, including Chuck Cassidy, Brad Ernest, and Gilberto Gonzalez, who will help you understand the complications that happen and how to take care of them. So with that being said, all yours, Jay.
All right. Thank you, Chai. So thank you, Chai, as our chairperson here at AO North America Hand Education Committee, who's helped put all of these series together in our educational efforts. We want to say thank you, Chai. And I'm Jay Bridgeman. I'm a hand surgeon here at the University of Missouri in Columbia, Missouri. And our faculty tonight include Charles Cassidy from Tufts Medical Center in Boston, Gilberto Gonzalez from Texas Tech University in El Paso, Texas, and then my friend and colleague who I've worked with for many years, Brad Ernest, who's the head of hand therapy here at the University of Missouri, centered at the Missouri Orthopaedic Institute. So these are our disclosure information, just to go over that quickly. And then for CME credit, we want to remind you that you can receive CME credit for tonight's activities. A link to an evaluation questionnaire will be sent at 24 hours after the conclusion of the series. It confuses some people. It's not after tonight, it's after the series is over. Upon completion of the link, you'll provide a claim credit to access your certificate for CME. And this is our content validation statement, just updating you on who we are as an organization, AO North America. We're an independent nonprofit surgery specialty society dedicated to improving the care of patients with musculoskeletal injuries. We don't endorse or promote the use of any product, service, commercial entities, and the equipment we use is for demonstration teaching purposes to enhance the learning experience. The Zoom etiquette, we've talked about this at other times on our webinars, but all microphones have been muted and the video cameras have been turned off. But we'd love for you to be participating through the question and answer box. So please send us questions and responses through the question and answer. Myself and the other faculty will be moderating, sorting the questions, and trying to get through the questions as we transition between topics. But the chat box is only for the faculty and the staff. Our learner objectives for this series. We want to identify common complications after upper limb surgery. And tonight we're focusing on tendons. We're looking to understand and evaluate investigative modalities for each complication, develop algorithmic approach to treat each complication. Tonight's agenda, after I finish the introduction, Dr. Gilberto Gonzalez is going to start with how to deal with the ruptured flexor tendon repair, as well as patients who have an incompetent pulley system. Between each subtopic, we're going to be joined by Brad Ernest, who's our expert therapist tonight. So we'll be discussing questions about each topic with him. I'll be going on about flexor extensor tenolysis at 7:25 roughly, and then we'll finish out with Dr. Cassidy about Boutonniere injuries. We'd like to try to wrap up somewhere around 8 o'clock, going through additional questions and answers, and hopefully adjourn by 8:15. So we've got a packed evening. Tonight's the second in our series. The last series that was on failed distal radius is Dr. Mudgal discussed with Dr. Mesra last week. Next week is Peter Ree from Mayo Clinic is going to do failed soft tissue repairs on May 19th. We've got a great continuing sessions, including session 7 on June the 16th. So please mark time on your calendar. We'd love you to be a part. And we have in person courses this year that we wanted to highlight as well. This is something we're getting back to after dealing with this with COVID. So June 25th and 22nd is our Fellows course, Life After Hand Fellowship, shared by Dr. Mudgal as well as Marco Rizzo in Tampa, Florida. So please look that up through our website. We'd love you to be a part. As well as in the fall, October the 20th, is the AO Trauma Hand North America Advanced Upper Extremity Trauma and Flap course. These are courses that also include cadaver labs, so we'd love you to be a part. Jeff Lawton and myself will be co-chairing the October session. We also have a couple of webinars that are not related to the Complication series, just to highlight. May 18th is on nerve transfers with Harry Hoyen. August 10th is DRUJ instability, followed by management of bone defects by Peter Ree, and malunions and non-unions with Jeff Lawton. So you can get more information about those, but please register so that you can be a part of those webinars in addition to what we're doing with Complications. So I'm going to remind you about the link to the YouTube and AO North America webinar that you can see after 24 hours. And now I'm going to pass the baton to Dr. Gilberto Gonzalez, who will lead us off with the failed flexor tendon. I'm going to stop sharing.
Thank you, Jay. Good evening, everyone. And thanks for being here. I appreciate the invitation. Let me see if you guys can see my screen, right? Okay, good. So we are talking today about post-repair tendon rupture and tendon polyp reconstruction. No disclosures for me. I'm going to start with two open questions. I understand that you guys have the option to choose your favorite, and we're going to go over the answers at the end of this presentation. The first question reads, 36-year-old male suffered a zone 2 complete FPL laceration 3 months ago. We went ahead and repaired it primarily, and the patient was lost in follow-up. Now the patient comes back, no FPL firing. So we have made a decision to proceed with a 2-stage procedure. And from all these options, which option do you guys feel that is the right option? Option number 1, it will be palmaris brevis as the most common allograft. Number 2, postoperative tenolysis is required in less than 30%. Supple skin, sensate digit, and adequate vascularity, it is adequate. It is necessary for these procedures. Preserved tendon sheets are required for the 2-stage reconstruction procedure. And number 5, full range of motion of adjacent joint, it is not necessary. So I'm gonna go with the next question. Hopefully you chose your answer. Let's see. Next question. 27-year-old male sustains an injury. I can tell you it is a zone 2 injury. You repair it primarily. 2 months later, the patient feels a pop, and while using his hand, and he's no longer able to flex the DIP of that digit. Patient is taken to the OR, and during the exploration, a 1.8 centimeters of scar tissue between the tendons is identified. The tendon sheath is found to be intact and allows a smooth passage of a catheter. What's the next step? Once again, here we have the 5 potential options. Number 1, a resection of the scar in primary repair of tendons. Number 2, resection of a scar in adjacent 1 centimeter of tendon, placing a Hunter rod. Number 3, debulking the scar with partial excision of the tendon. Here is the poll. Number 4, a resection of scar, harvest the ipsilateral palmaris longus for reconstruction. And number 5, resection of a scar in proximal tendon and with tendon transfer to the adjacent digit. So choose your favorite, and we're going to go over them at the very end. Objectives for this lecture is going to be rupture for flexor tendon repair, rupture after extensor tendon repair, and poly reconstruction. So in general, an overview, the flexor tendons, they can have a 15 to 25% re-rupture rate. It depends on your sources. Some of them, they can say up to 30%. I guess the main thing here is to consider the 1 centimeter measure. So if the less than 1 centimeter of scar is present, then the option is recommended here to resect the scar and perform a primary repair. If more than 1 centimeter is present, then it's to go with a tendon graft. Now, if the sheath system it is intact, allows you to pass a catheter, and you feel that it has good vascularity, definitely your option should be perform a primary tendon graft, a one-stage procedure. But if the sheath is collapsed, especially on those patients that the rupture was identified way after the rupture happened, then the Hunter rod it is the option to go. Here a little drawing about how complex is the flexor tendon system, not forgetting the importance of the vinculus and all these tendons connected by a sheath system that goes all the way to the wrist. If the rupture, as we mentioned before, it is detected soon enough, and then we go ahead and we identify that it is less than 1 centimeter, an end-to-end repair should be attempted. Usually this happens on the acute phase of the process, because if this takes longer to be detected, then the scar grows bigger. Sometimes these acute ruptures can happen during therapy, or because patient remove the spleen very soon, or sometimes if we consider the patient is not making enough gains and we proceed with tenolysis, even these ruptures can be present. Here are some clinical examples of what we mentioned before. Patient sustained a rupture, no longer able to flex the DIP of that digit. During the exploration, the gap, it is determined to be, after the scar has been resected, it is determined to be less than 1 centimeter, and end-to-end repair is performed. Now, if we have a patient that we go there and then we identify this gap to be more than 1 centimeter, but this sheath system it is intact, it is in continuity, and allows you to pass your catheter, then a single stage tendon grafted is recommended. On this single stage tendon grafted, you have multiple options that we're going to mention later. Or also you can have tendons in the vicinity. Here is an example going from the top to the right. You can see a rupture of the FPL. Choosing the FDS of the ring finger, transected this tendon distally, obviously after making sure that the ring finger has a competent FDP, and bringing this tendon proximally through an extra incision done proximal to the carpal tunnel, and then this tendon rerouted and suture distally in order to regain flexion of the FPL. Here is another example of a patient that we see, 60-year-old male, previously repaired tendon. We can see here at the level of the A1 pulley. The patient has this not normal cascade with this finger is more extended. When we go and explore the tendon, the gap is determined to be more than 1 centimeter, but the flexor pulley, the sheath system, it is competent. So we decide just with a small graft, repairing the gap and regaining flexion of the tendon. Next slide. Okay, good. Sometimes you go there being very enthusiastic and thinking that you're going to have a sufficient sheath system, but when in reality what you find that there is no more sheath system, and then that's when you pull the trigger and you decide to go with the two-stage procedure. It is important when you're doing these revisions on these patients, your patient has to be consented for end-to-end repair versus one stage or versus a two-stage. Because sometimes patients are not super excited when they wake up and they know that they have the Hunter rod and they got to go to another procedure like 3 or 4 months later. Donors for a tendon, if you do a single or two-stage procedure, it can be palmaris longus. It's easy to take it just because it's there in the vicinity. We know that up to 80% of the population, they have it. Even that sometimes you ask the patient to bring your thumb and your pinky together. And even if you don't see the PL, sometimes based on the patient's anatomy, the PL is there. So don't settle. Just always try to palpate and most of the times you're going to find it. Plantaris and tendons of your leg and your foot. Also for the extensor tendons, the EIP and the EDQ, since they are expandable tendons for extension. They are a very good options when you are trying to repair extensor tendons. Complications, we're going to explain this in detail later, but we can have a lumbrical plus finger or a quadriga effect. Now, if you have a patient that the gap is longer than 1 centimeter and your Poley system is not sufficient, then you got to go with the 2-stage tendon reconstruction. Now, these patients sometimes you got to choose the ideal patient in order to do that. Indications that we mentioned, there has to be a loss of FDP and FDS on that finger. It is important that protective sensation is to be present because patients are going to go for a very specific therapy. The range of motion needs to be present. If it's not present at the moment of when you do your first stage, you do your proper releases in the therapy is addressed onto that, so you can have very good range of motion by the time that you do your second stage. There has to be good quality of soft tissue, and the patient, of course, has to cooperate with you and has to be very motivated. Some people are detractors on doing this 2-stage procedure because they say the lack of vascularity on these tendon grafts. Some animal studies have demonstrated that from week 1 to week 6, there is a revascularization of these grafts that we use. So let's show these little images of the first stage of this procedure described by Hunter in 1965, where we excise the old tendon, we treat any previous contractures. If necessary, we reconstruct A2 and A4 pulleys. It is better to do that on the first stage than in the second stage, and insert this silicone tendon rod, which you secure it distally, and proximally you bring it all the way to your wrist. And then it usually takes a good 3 months to go to the second procedure. Some people will go a little bit faster, up to 2 months. Some people will take longer for 6 months, but ideally shouldn't be taken any longer. I remember last year I got a patient who had all 4 in a different practice, all 4 Hunter rods and fingers, and then he came back 3 years later. So there was not too much to do about it. So for this second stage, what you do, it's you don't make the extended incision again. You just make an incision proximal and distally. In one of the ends, either proximal or distally, you suture your graft, which you previously harvest, and then using your tendon, your rod, you pull the tendon through the sheath that has been made through all these months that the silicone has been in place. And then you secure your tendon. And one of the most important steps of this operation is to have the adequate tension, which is noted by a good flexion cascade. Stage 3, I mean, it's not stage 3 itself, but I mean, a lot of these patients are going to require a tenolysis. Just briefly mention this Pavina-Holevic procedure, which is a modification after Hunter described in 65, where you're using your FDS and FDPs as the graft, as the donor, and there is no need to harvest tendons somewhere else. Some people are in favor, some people are not too much about it. Now, going into the extensor tendons, very specific anatomy. We know all these different compartments on the dorsum of the wrist, the extensor compartment that is very, very important. And the incidence is less than the flexor tendon ruptures. People say around 5%. And but as previous, the flexor tendons, most of the ruptures occur on the first 7 to 10 days when the tendon is weaker. It is important to have an early recognition, and the tendon reconstruction for late rupture is ideal. So here we see the different zones for the extensor tendon. Let's not forget, when you are in the setting of not a clean laceration, but more like a trauma case or more like more structures involved, where a rupture of one or multiple tendons can be present, and then that becomes a little bit more challenging when you are trying to go with the repair. The beauty, well, not the beauty, because there is no beauty about this, but the easy part of the redo extensor tendons on the back of the hand versus the flexor tendons is that you have tendons right there in continuity, and you can do other procedures like bringing 1 or 2 tendons onto another functioning tendon, or sometimes the junction tendinosa is making you your life easier. I'm not going to comment too much about this because we'll have a conversation, but there are also some ruptures on the Boutonniere area. This is not specifically a tendon rupture case, but more and more we're using bridge plates. And I always tell my residents, sometimes it's important to make an extra incision on the wrist, but just make sure that you are not putting your plate on top of the EPL, because that's going to be a tendon rupture and it's going to be a disaster by the time that you remove the plate and the patient is not extending the thumb. Local options for doing rerouting of the tendons can be from volar to dorsal, and you can bring flexor carpidialis, for example, to try to repair a massive extensor DT communis tendon. Now, we know that A2 and A4 are very important pulleys for the avoiding bowstring, and this is it's important when we plan our reconstruction. I'm gonna go a little bit faster because we're running out of time, but here just leaving you a couple papers that consider very important as review papers on flexor tendon injuries and bailout technique. So sometimes your patient is not a candidate for a tendon reconstruction, and especially on the ulnar digits, you might choose to do a DIP fusion in order to get a good grip of the hand. In summary, the flexor tendons is a very demanding pattern in hand surgery. It is important not only to reestablish the tendon continuity by the gliding mechanism. It involves the type of trauma, contamination, other structures involved. When we repair our tendons, we got to be thinking, I'm going to repair FDS and FDP, half of FDS of the FDP, or just FDP. Up to 30% of rupture can be present. And we know that the weakest of the tendon is between day 6 and day 18, most of them around day 10. Don't forget the 1 centimeter gap, more or less. Quadriga, it's important not overtension in your repair so you don't develop this condition. Poly reconstructions, when they are necessary, they should be done on the first stage. And key to success is a good communication with your hand therapist. And just super quick, our question number 1, the preferred insole, it is to having a supple skin, a sensate digit, and an adequate vascularity are required. And the question number 2, a resection of the scar, harvest of the ipsilateral palmaris longus tendon for tendon reconstruction. And here are my references, and thank you. I try to stay on time.
All right, thank you. If you want to stop sharing, and I'll start mine. And as we go in the segue to my talk, a couple of things that I'd like to discuss with Brad. Now, Brad, you've been a hand therapist for 27 years. You and I were discussing that this evening. And over that 27 years, the breadth of the techniques that you've been exposed to as a therapist, from maybe even just like a 2-strand Kessler repair plus or minus an epitendinous technique to now the multi-core early active motion protocols. Do you think that the rupture rates you've seen lessen as far as ruptures over that period of time? Like, what you teach a lot of younger therapists, mentor therapists as the head of hand therapy. What do you just teach them about flexor tendon rupture as you try to help the person with a flexor tendon repair?
So I would say in the early days, so I started in the mid 90s. And yes, those, like a 2-strand repair was still present and kind of common practice, and they didn't hold as well. So rupture rates, I would say, were higher. As a therapist, we were pretty nervous about flexor tendons. Like anytime we'd have a flexor tendon patient, there was always this air of being conservative. Whatever you do, don't move the finger, things like that, for, sometimes up to 3 weeks. But as 2 things happened, one, people got so stiff, and yes, they wouldn't rupture, if you were super conservative, but you wouldn't have a very functioning digit. And I always thought in my mind, that's not a good trade-off. Mm-hmm. As surgery techniques improved and just better techniques and better materials and so forth, those rupture rates for sure have gone down. And I was thinking in my mind, coming into this talk tonight, it's hard for me to think of the last rupture I've had. I would say for our practice, it's 10%, if not less, rupture rate.
Do you think there's some factors about the digit that can predispose people to rupture, like as a perspective of a therapist? In other words, if patients have more stiffness, they could have, maybe there's more work in the flexor sheath, more friction in the flexor sheath. work of flexion that's contributing to it, or they're more swollen. Do you think have you seen that?
Yes, for sure. So increased edema, delayed. Let's say the whole case was just, got delayed. That normally doesn't help. I think the type of patient, if I have a 19-year-old male versus a 60-year-old female, we know that those behaviors of a 19-year-old male could, they don't always listen.
Sure.
So you can have just the patient not helping themselves. Certainly an infection or anything like that, those type of complications, I think can wreak havoc for a flexor tendon.
In patients that that they have some pulley incompetence, do you think that the rings are? How successful do you feel that the rings are that you use in therapy to try to help with during the healing phase? For example, if they're not as successful, is it often, because I can't think of the number of pulley reconstructions I've had to go back and do. It's usually related to trauma when there's just not, the massive trauma to the digit. There's not much native pulley system there, but like late reconstruction or late need for pulleys, what's your opinion about that?
So in terms of pulley reconstruction, especially if it's done later, I think it can complicate things. I think we have to, I think it's a very delicate surgery if you're going to reconstruct pulleys later, not primary, because I think you can really get some complication with excursion and just not poor excursion of the FDP, just not getting that composite fist. For sure. I think it can be very troubling. So I get a little nervous about those, secondary pulley reconstructions. Sure. And I can create rings and so forth out of thermoplastic material to help the patient. Maybe they would wear the rings if they had a job that required a little bit more force, but they wouldn't wear them all the time. So sometimes I can just create external support just to help them along, and they still get good excursion.
All right. Well, thank you so much. We're going to go on to the next topic is complications of tendon surgery, specifically tendon adhesions and tenolysis. And we'll start with a case. This is a case of mine. This is a 57-year-old female who was sent to me. She complained that her small finger is stiff. And she had a prior closed proximal phalanx fracture treated by an outside institution. Their technique was closed reduction and pinning. And then after the procedure, she had 4 weeks of casting, strict immobilization. At the time that the cast was removed, a month later, she was very stiff. She said, they had sent her to hand therapy. They were working on trying to regain motion, but she really just wasn't satisfied and wasn't gaining much. She reached a plateau very early and didn't notice much improvement at all. So on my exam, she had minimal active motion. The passive motion of the MCP joint was minus 15 to 45 degrees. The PIP motion was 10 to 40 degrees. And it was painful. The exam to try to achieve passive flexion was painful. The radiograph showed that the fracture was well healed. It was well aligned. And this just kind of gets into the start of my talk about what's the treatment plan? Like, how are we going to go from this digit and get any meaningful motion? How could we make a treatment plan for that? So that's what my talk is about. Now, we know that stiffness after hand fractures is common. The goal really is prevention, early active and passive range of motion. We want stable fixations that we can receive, begin early motion protocol, as well as work on edema control. But I think early therapy and prevention is the key to try to lessen this. But even despite that, this is a prospective study by Eve et al. From Injury 1996. It was a prospective study following 929 hand fractures. And even in their series, 29% had flexor and extensor adhesions requiring surgery. So it's a very high number. So it's common. And then the decision-making can be challenging. It's often kind of like this road sign where it doesn't, I don't know which treatment plan to choose that we're going to get through it and the patient's going to be happy with it or have a better finger. Maybe the finger it'll be different, but it's not better. And this is a great paper in 1996 by Dr. Schneider from the Philly Hand Center. It's a great summary of not only kind of the concepts of evaluating patients, the principles of the surgery, but also just going back and deciding who really meets a good indication for this. And his recommendations are, number one, the patient should have plateaued with therapy. Now, when I see people and it's only been a month or two, it's not surgery that we're choosing. It's going back to therapy, making sure that they're getting the correct therapy, the correct protocol. If they failed therapy, they plateaued, then you want to be looking at other factors, including that the fracture should be healed and well aligned. Hopefully that they have full passive motion, which is not often the case, but that would be ideal if they have full passive motion. That the skin, soft tissues are healed and they're pliable or they're supple. The tendon systems, extensor and flexors are intact, and that the joints are unaffected. So, for example, if they already have severe post-traumatic arthritis, that's going to lessen the result of any planned release. And then most importantly is that you have a motivated patient and that they have access to therapy. And I know that in some locales, like where I practice, the Medicaid system in my state does not pay for therapy. So if we're going to embark on that type of difficult treatment plan, we have to write exception letters and proposals and things like that to try to get that approved. Even doing some therapy before surgery can be helpful, which I'll talk about later in my talk. But the key here is at the point at which they failed therapy and you're anticipating or planning a surgery is, where's the source of their stiffness? How can you elucidate like the different patterns of stiffness to kind of come up with a unified treatment plan? And this is an article, very well-written article describing the different patterns of stiffness and how to examine patients from Curtis in 1954. And some of the major concepts to consider are comparing, in a stiff finger, comparing their passive motion to their active motion. Now, in a stiff finger, limited motion, if the passive motion is very minimal and the active motion is the same, the diagnosis is very clear that they have joint contracture. Now, that would be like a foundational baseline diagnosis, because if you have joint contracture, it obscures your ability to assess the extensors and the flexors. So they could have that as well, but in that setting, definitely they have joint contracture. In other patients, if their passive motion exceeds their active motion, then that can safely point to the joints are supple, but without active motion, there's tendon adhesions. And so, based on the motion that you're checking, it could be a flexor adhesion, it could be extensor adhesion. But those are the two concepts of comparing passive motion and active motion, how that can guide you. The next thing to consider would be, what's the pattern of their injury, or how was their fracture addressed? Like, was there a dorsal approach? Was there a volar injury, volar soft tissue injury? So in the dorsal injuries, if they've lost flexion, so you can't passively flex the digit and they have an extensor lag, that's most commonly related to extensor adhesions. And so that's something to be thinking in mind. If this person had a dorsal injury, dorsal incision, dorsal approach, that pattern would guide you to understand that it's extensor adhesions. And then the opposite for the volarly injured finger, if you can't passively extend the digit and they've lost active flexion, that's most commonly correlates with the flexor adhesions in the flexor system. And then, as I said before, if they don't have any passive motion at all, that's likely joint contracture. But the thing to consider is, in the difficult cases, they can have a combination of all three, actually. Okay. And then lastly, the exams from Curtis's paper that are very helpful to understand is, when you examine a digit, it's important to examine it in different positions. And that can guide you to the source of their adhesions or contracture scar as well. So the upper right is testing the passive flexion of the digit based on the position of the wrist and the MCP joint. So in the upper right figure, in the number A, or the letter A, the A figure, the wrist is extended, the MCP is extended. And when you are in that position and you're able to get the finger flexed, that's a good starting point to now do your comparative exam, which is in figure B. And this is when you flex the wrist and flex the MCP joint. Now, when you do that, you're increasing the extensor tone through passive tenodesis, especially if it's stuck in scar, that's even exaggerated. So in this patient in figure B on the upper right, you're unable to flex the PIP and the DIP joint. And so this comparison between wrist extension, MCP extension, now wrist flexion, MCP flexion, this difference in the fact that you cannot flex the PIP and the DIP joint in those comparison positions that is only one diagnosis, is the extrinsic extensors, the EDC, is, for example, to the long finger. For intrinsic, this is the intrinsic tightness test. For the intrinsic adhesions, it's the same concept, different positions, but the results are different. So in the figure A here on the left, the finger is stiff. And so what you'll do to address this is extend the finger, supporting it with your thumb, and now trying to flex the digit, and you're having difficulty flexing the PIP and the DIP joint. Comparing that to figure B, which is by flexing the MCP joint, now all of that tightness from the intrinsics has gone, and you're able to passively flex the digit. So, but the comparison between these two positions, this figure in the lower left, with the MCP joint extended, that really stretches out a scarred and trapped intrinsic mechanism, and so that's why the finger is stiff. And then when you flex the MCP joint, that's all placed in a more loose position, a more lax position, and so allows better passive motion and flexion of the digit. And so that's the intrinsic tightness test. And then lastly, the third figure in that paper, in Curtis's paper, was just, it doesn't matter whether the wrist is extended, MCP is extended, MCP is flexed. It doesn't matter. The PIP and the DIP joint are stiff in both relative positions, comparative positions. And so that would indicate a joint contracture. So all of those things, all of those concepts can help you come to an understanding, a better understanding. So let's apply that to my patient. So this lady, she had a stiff finger. I could not get the MCP flexed. I could not get the PIP flexed. I was in my treatment plan considering this is going to be extensor tenolysis to a dorsal approach. And if the tenolysis alone doesn't gain me the motion that I need, then we're going to then what we're going to do is joint contracture releases, which I performed at the MCP and the PIP level. And this is where we were at the end of that. Oh, sorry. Let's go back. Let's see here. This is at the end of that first surgery. And what you see here is she has full active extension now. This is done under local anesthesia with epinephrine. So at the end of the surgery, she's awake and she can comply with the exam, but she can't actively flex. But what's important to see here, I give a resident holding the towel. What's important to see here at the end is we can passively now flex her digit all the way to the palm, which was not the case at the beginning. Like she could not get that amount of flexion. All right. So at the end, I chose to stage this one. I did not go to the flexor side, but we did 3 months of hand therapy. And this is where she is in clinic at 3 months, full active extension. And then you can see her own thumb is holding the small finger now in a fully flexed position. So we've had a great improvement, but we're still lacking active flexion. So now we're in that setting where passive is great, but active is lacking on the flexor side. So that only leaves one diagnosis left, which is flexor adhesions. So when you are anticipating the stiff finger, you've got to be competent and comfortable with different approaches. So a lot of these may have dorsal scarring. They may need tenolysis on the extensor side. So they may have already had a dorsal approach, for example. So being familiar with dorsal approaches to the digit is important. Curtis's paper, they discussed doing a mid-lateral approach and getting to the extensor and the flexor side through one approach. Or you may consider doing combined, either a dorsal and a volar approach. In my practice and in my results, I tend to avoid doing those on the same day. If you're going to do 2 incisions, dorsal and volar, I try not to do that for digits. I think it makes them too swollen, which leads to a lot of recurrent stiffness. So I tend to stage mine, is why I put question marks. Some people stage it, others don't. I tend to, if I'm going to do both sides, make a plan to do an interval of therapy between the 2 stages. But the key is that soft, supple, soft tissue envelope. And so you need to anticipate that you need to create full thickness skin flaps, and often that has to be done sharply. You're not going to get any blunt spreading. You're going to have to find a plane sharply with scalpels to get between the tendon and the skin envelope. Principles of the surgery. Well, one would be the anesthesia choice. Doing these with epinephrines really changed my practice. It's really helped because I don't worry about the tourniquet time. The patient can be sedated, and it doesn't matter if I'm struggling in the case, it's taking longer. We're not going to run into a point where they're having tourniquet pain. It's faster than a beer block for me. So I've really avoided beer blocks since I've started to use local with epinephrine. But the key is to be able to do an active motion test. You can simulate that through pulling on the tendons proximal to the zone of the scar. But there's nothing better than the active motion test in my mind. And you can take a video of it with your phone and use that in the clinical record, as well as showing the patients, hey, this is where we had you on the OR table. For the extensor side, we talked about releasing scar between the tendon and the skin, but also between the tendon and the plate, or the tendon and the bone. So you're working on both sides. And then after you've completed your loosening of the tendon, you're trying to assess their passive flexion. And if they're still having blocked flexion, if they're still having tightness, they're going to require capsulectomy, either dorsally at the MCP or the PIP joint, just depending on the zone of their injury. For the flexor side, I don't hesitate to open up, and either if they have minimal A3, I'll just get rid of what's left, or I'll open it, and I don't try to do a formal repair of A3 at the end. I'll even remove some, depending on the zone of the scar of the adhesions. I'll remove some of A2 or some of A4, but I do try to preserve some portions of A2 and A4. But I over time, the motion, getting better motion, I think is of greater value than trying to preserve, the full A4 or the full A2. You want to, there's instruments that are designed to help you with this. I would just say use those with caution. The key thing is you want to protect the tendon. It's easy to lacerate the tendon if you're using sharp instruments around a scarred tendon. So you want to be careful. You want to be very careful. If you have a lot of scarring in the zone around FDS, some authors recommend just going to a single flexor finger. So getting excising FDS, that is an option. And then, of course, either the dorsal side or the volar side may need capsulectomy to restore the passive motion of the joint. So you may need to do a volar plate release. You may need to release the check rein ligaments and partial release of the collateral ligaments on both sides. So this is my patient that at 3 months, we went back for the second stage. And then this one, you can see the incision on the flexor side. So we did a zone 2 flexor tenolysis. And this is where we are at the end of that procedure. You can see she's fully actively extending, and now she's fully, she's flexing down to the palm. She doesn't have full flexion. She doesn't have full flexion of the PIP. She doesn't have full flexion of the DIP. But now that she can reach the palm, that motion that she exhibited on the table in the OR, if we could keep that, that's the goal. She'd have excellent function with that. Now, what's the outcomes of tenolysis? There's not a lot written about tenolysis. The total number of articles is like less than 5 articles. And this is the most recent one, is in the Journal of Hand Surgery, Europe, 2008. It's not a very large study. It's retrospective of 12 patients, 12 fingers in 12 patients. The mean follow-up was 15 months. They were all P1 fractures, except for one patient who was a middle phalanx fracture, but they were treated with either closed treatment with a splint, closed reduction in percutaneous pinning, or open reduction with a K-wire technique. And what they were interested in was looking at the fracture type, whether it was simple versus comminuted, open versus closed fractures. The timing, was there a delay after they were treated with surgery before motion was started? What was the delay between when they got stiff and their tenolysis? What was their starting total active motion, total passive motion? And what they found, the total active motion after flexor tenolysis, just flexor tenolysis only, they had average total active motion of 219 degrees. This represented an average improvement of 109 degrees of total active motion, ranging from 50 to 165 degrees. So fairly significant improvement in range of motion. And their how they graded their outcomes on the Strickland criteria was 3 patients had excellent, 5 had good, and 4 had fair. They had no poor results in their group. But it was a very small study. They found no correlation was found between these factors in final total active motion. So, for example, there's no correlation between fracture type, whether it was open versus closed, the time to tenolysis, or the time to mobilization after their fracture treatment. That did not correlate. The only thing that correlated was their preoperative total passive motion, which those were patients that had involvement on the extensor side, including PIP contracture that they theorized was affecting their outcome. But the main thing that they talked about was just the variability. There wasn't a way to predict who was going to do well, who was going to do poorly. The variability of where the scar was, that was highly variable as well. So just to finish, we really need better data. What's lacking is we need better data, better prospective studies, and that the results are varied. And so I discuss that with my patients. I think it's something that should be done. I do counsel them that we can try to make the finger better, but the result of it and how much improvement they're going to have, or if they're going to have recurrent scarring, that's something that I think is guarded. And so I talk about it with my patients. Take-home messages. Prevention is really the key. I think prehab, like doing therapy before any planned complicated surgery, tells you two things. Number one, can you get some improvement in the motion, which can make your surgery a little bit easier? And two, is this a motivated patient? How can you measure if they're motivated? Well, doing some therapy before you plan a large reconstruction could be very helpful. The diagnosis, we talked about multiple exams, seeing people over time and trying to ferret out what's contributing to their stiffness. Having the therapist look at it. I do a lot. Brad, Ernest, and I have worked together for many years, and getting Brad's input on the stiff finger can be helpful to me, as well as colleagues in clinic, other hand surgeons coming in, taking a look at it as well. Planning a stepwise surgical technique, and then deciding, should this be staged? Are you going to need to work on both sides, and maybe they would do better with a staged approach? And then the fact that the outcome is variable. And these are my references. So I'm going to stop sharing in the effort to keep us on time. I'm going to ask Brad one question. Brad, I had to do a lot of educating with patients to prepare them for the outcome. And how do you do that with a patient who's had, or it's either planning tenolysis, you've already been involved in their care for the fracture, and now they're going to go forward with tenolysis. How do you counsel the patients who are facing tenolysis or have had tenolysis?
Very good. I think it's very important to have that conversation with them, to let them know that therapy is going to start within 24 hours of the surgical procedure. There won't be this, downtime of 5 to 7 days. We're going to go live right at, the next day. You're going to have therapy already scheduled, ready to go. So there will be no logistical, complications. We see them on the weekend. So we do daily therapy for 7 to 10 days. I let them know it's going to be a tough road in the beginning. It's uncomfortable. I don't want to sugarcoat it, but it's manageable and they can have amazing outcomes. So you're a case study. I worked with that patient and she was very pleased with her outcomes, and it was a lot of work. But it really showed the dynamic of the surgeon, therapist, and motivated patient working together.
Do you think that there are some, some fingers where the patient's contemplating tenolysis, and you think, no, probably not? Like, this is not one that I would, as a therapist of 27 years, what are some things that you'd categorize like, if the patient's having some of these other issues, you may call me and say, hey, Jay, I think maybe this one, we maybe shouldn't do it.
So things that come to my mind are a patient who is inconsistent with therapy, in terms of their attendance, or it seems to be lacking on their home program. You get the sense that they're really not doing the proper work at home. Their pain tolerance. If their pain tolerance seems to be exceedingly low and they just are really hard to move, hard to handle, always kind of, very like, please, don't move my finger, that would make me very nervous for a tenolysis case. And then I would say if you get any sense that a patient has an agenda that is other than I want to get full function of my hand, mm-hmm. I would be nervous about underlying agendas to where, they don't feel there's not that motivation for improvement.
Those are great comments. And we'll have some time at the end to go over some more concepts as well. But we're going to transition now. Dr. Cassidy, you can go ahead and share screen. And he's going to finish us with Boutonniere.
Thank you very much, Jay. All right. I have no disclosures with respect to this talk. So the Boutonniere is defined as a deformity of the digit with flexion at the PIP and hyperextension at the DIP. And with respect to the pathology, it's all about the axis of rotation, and it begins at the level of the PIP joint. So a little bit of anatomy review. Here we have the lateral bands depicted in blue, and they're stabilized dorsally by the triangular ligament just distal to the PIP joint, and on the sides, the transverse retinacular ligament depicted in purple. And with Boutonniere deformity, the lateral bands translate volarly and end up volar to the axis of rotation and contribute to the deformity. So the deformity may start, for example, with a central slip injury, but then over time, the lateral bands migrate volarly and get stuck in that position. They can no longer extend the PIP joint. They actually flex when they fire, but they exert a hyperextension force on the DIP joint. So a Boutonniere often is initially supple, and this is a beautiful illustration contrasting a flexion contracture and a Boutonniere. So if you take a look here, as I extend the PIP joint of this finger, you can see that the DIP joint hyperextends. As I extend the PIP joint of the ring finger, see the DIP hyperextend. So the lateral bands are volar to the axis of rotation of the PIP joint, and they're stuck there. And it's sort of like a step-up hinge, like an oblique retinacular ligament. As you extend or actively or passively extend the PIP, the DIP hyperextends, and that contributes to the deformity. One area of confusion is when a patient comes in with a flexion deformity, is it a Boutonniere or a pseudo-Boutonniere? So is it a joint contraction mimicking a Boutonniere, or is there really a, quote, central slip, quote, injury? And so for that, we have the Elson test. And if you look at the illustration on the left, with a central slip injury, the extensor force transmitted through, for example, the EDC ends up bypassing the PIP joint and ends up exerting an extensor force onto the DIP joint. It was described as a tabletop test, which I find is a little bit confusing, but it's illustrated in the middle. On the right is an illustration from actually one of the hand talks, which is incorrect. So they're actually backwards. So if you have a central slip injury, as the hand to the left would show, if you push the middle phalanx against the middle phalanx of the other finger, if the central slip's intact, you won't be able to extend the DIP joint. But if the central slip's disrupted, the extensor force goes to the DIP joint, which straightens out. So this is how I do it in the office. And I hold the PIP joint in flexion, have the patient extend against my thumb, and see if there's any tension in extension or if it's floppy. So not only is acute central slip injury a cause of a Boutonniere, other things can cause, like a proximal phalanx fracture, inflammatory arthritis with attenuation of the central slip over time, hyperlaxity, Dupuytren, as you see here, a Dupuytren contracture with a pretendinous cord, and eventual migration of the lateral bands can cause a Boutonniere. And then neuromuscular, which is more complex. There's a classification. Initially, as I mentioned, the Boutonniere tends to be supple. Later, you get a fixed contracture with contracted lateral bands. Stage 3 is a fixed contracture with joint contracture. And stage 4, like the one on the right, is arthritis, and that's a different treatment algorithm, which we won't discuss tonight. So over to treatment. First, it's important to remember which is more functional, Boutonniere or swan neck. Clearly, a Boutonniere. Flexion is function, but patients really hate the appearance, especially when they have a lot of DIP hyperextension. But flexion is function, and so we don't want to sacrifice flexion in attempting to treat this. So the first goal is to obtain passive PIP extension. As Jay mentioned, we want to try and reduce the number of problems that need to be addressed surgically. And I think it's a mistake to try and correct everything at once. They often end up disasters. So we need to correct PIP extension. And it may seem like it's never going to straighten out, but oftentimes if they haven't been operated on in the past, it will. So on the left, we see a dynamic extension split. In the middle, a static progressive extension split. On the right is serocasting, which is great if
if the PIP contracture exceeds the limits of those first two splints, you can have the therapist do serial casting, which can hopefully achieve some improvement, and the patient's instructed to flex the DIP joint to help to stretch out the extension mechanism at the same time. So the next goal is to rebalance the forces across the PIP and DIP. So we can weaken the DIP extension, augment the PIP extension, or a combination of both. So the simplest one is an extensor tenotomy. And the ideal candidate is someone who has mild deformity, full passive motion, and the DIP hyperextension equals or exceeds the PIP flexion. So that example that I showed earlier, this one, as I extend the PIP, the DIP hyperextends, that's a good one. So an extensor tenotomy is likely to work. It's not going to work on the ring finger. You'll create a mallet finger. You see that. So the patient must be able to participate. Jay mentioned about wide awake surgery. You got to do it under local or local sedation. An incision over the middle phalanx. I like this illustration because I disagree with it as well, because if you cut that tendon distally, you're going to end up with a mallet finger. You want to do incremental release through the triangular ligament area, not through the terminal tendon. And I always inform the patient about the possible need for DIP pinning because they could end up with a mallet finger. And ideally, post-op, you don't want to splint them. If it works out well, mild deformity, it's an elegant, simple operation. All right, how about augmenting PIP extension? So as I mentioned, the lateral bands get stuck volar to the axis of rotation. And if you release the transverse retinacular ligament on both sides, it'll allow the lateral bands to migrate dorsally, right? Like an incision like that. And this is someone I operated on today, actually, somebody who had surgery in the past. And real life is not quite as simple as those illustrations, but you can see here from a curvilinear dorsal incision, which she had in the past, you can access both sides. So the probe is under the lateral band on the ulnar side. So I've released the transverse retinacular ligament. You can access the joint from there if you need to, and then flip the skin over and you can release the transverse retinacular ligament on the other side. And you can see this one is much healthier, this radial lateral band more distally. So what about tightening things up? So we've allowed the lateral bands to rotate dorsally or translate dorsally. You can suture the lateral bands to each other dorsally. And that's a really simple way of tightening things up and make sure the lateral bands end up dorsal, but it links PIP and DIP motion. So as the patient flexes the PIP joint, the DIP joint gets tighter. And that's not how that extensor mechanism is designed. But you can relax it by doing a limited extensor tenotomy distal to where you bring the lateral bands up. And so that'll help augment PIP extension, weaken DIP extension a little bit.
Chuck, can I ask a question just for a second?
Sure.
When you're describing the limited release, you had said that prior as well. Is it like a step cut lengthening, or you release 30% of it or 50%, leave the other half intact? Like how do you technically do that? Like I feel like I need to learn how to do that better. Yeah.
So I've changed my ways a little bit, and I used to start in the middle and then work my way out to this, work my way out to the side. And I was taught to do it in an oblique, like I demonstrate there, and it sort of slides. And you don't suture it in a lengthened position or do a Z or anything like that. You don't need to do that. But it's really the lateral fibers that are the ones that are contributing the most on the margins. Those are the ones that are really causing that flexion at the PIP and hyperextension at the DIP. So if you start on the lateral side and kind of work your way toward the middle. But as I mentioned, if you get really distal, you're going to cause a mallet finger. But that's a great point. I don't think you have to do anything crazy about a Z or a flap or anything like that. You don't have to sew anything together. It'll heal.
Okay. Thank you so much.
Sure. And, I'm kind of poo-pooing this method, but it's simple, and you can certainly do it. People do it for silicone arthroplasty through a dorsal approach, but it does compromise the total digital flexion because they're connected, right? More PIP flexion, less DIP flexion. So there is the option of a lateral band transfer that was described by Matev, and there's several variations. And so here's the illustration. So you take one lateral band, transect it, and then insert it into the stump of the central slip, and then take the other end and insert it or attach it to the other lateral band. And you pin the joint in full extension for 3 to 4 weeks. I've tried it. I don't really like it. A Y-shaped graft. This is intriguing. I've not done this. This was published last year using a palmaris longus, and the palmaris longus is split. And there's a bone tunnel with exits on both sides of the middle phalanx, and then the tendon is split, loops, that goes through the bone tunnels and loops around the lateral bands to bring them back up and sewn to itself, and you use the tendon to bridge any gap that is created after you excise the abnormal central slip. So that's an article worth looking at. What about just tightening the central slip? What's the impact? Well, there's really no literature, and so this is as close as I could come. This elegant study that we all know from 1998, where they looked at both shortening and angulation, but there's a 12-degree extensor lag for every millimeter of shortening of the proximal phalanx. So you can kind of translate that into what would happen if I tighten up the central slip a millimeter or 2 or 3, and you're going to get something, I think, somewhat similar, although it may stretch out. So here's an example. You excise several millimeters of the central slip, and then you advance the tendon into the bone. So obviously you need to incise the interval between the lateral bands and the central slip, and you bring it forward. And doing that, you're actually relaxing the lateral bands to some degree. Another option, and this is my preferred one, is a YV advancement. So it's distally based. It's sort of like a chamois approach. We distally based, leave the central slip intact, and then make it a Y like that, and then advance the Y proximally. And you have multiple points of fixation. And so here's a patient of mine who has JRA, Boutonniere deformities, the left ring and small finger. The ring is really more of a Boutonniere, but he had surgery on his other side, and someone did a single stage contracture release and extensor augmentation, and it did not work at all. So we ended up doing a digit widget. So staged this, corrected his flexion contractures, and got him to 0 at the rings, minus 15 at the small. And here's how he looked pre-op. So you can see ring is probably a better example, but it's kind of the same problem in both. And here you can see the attenuated central slip and synovitis. His joint was actually in good shape, though. And there's the distally based V. And flipping that up, you can see the joint actually looks good. Extend it in a Y configuration and then pull it proximally like that. And here it is pre-op and post-op. And this was a not totally wide awake sedation case. And I think this is a great opportunity to have the patient participate. Now, you know that it may stretch out a little bit. These have to be protected, and we should really talk about how to do that. It's really tough to hold a PIP joint in full extension. How about combined contractures? So a combined PIP contracture release and extensor augmentation is a big ask. It tends to either compromise flexion because you're holding him in extension, or you make it really tight, or accept recurrent PIP droop because you have to have them start moving at some time. So here's an example of a patient with a really bad Boutonniere deformity. You can see no flexion of the DIP joint, really. And this is passive extension. So not great correction there. You can see the DIP is hyperextending almost 90 degrees. And so in this example, what we did was an extensor tenotomy, a different type, though, than what I had mentioned, and pinning, and a digit widget. So you have to think about the skin, too, if it's that contracted. So you can do a VY. So you make it a V, and as the finger, and then release the terminal tendon, and you have to release the capsule sometimes. I had to in this case, and then let the finger flex down, and then close it in a Y configuration because it's going to be too tight. You can't get it back otherwise. So you have to allow the skin to lengthen. And this is the patient after 6 weeks. You could see full extension. The DIP joint was pinned in extension. And this is her at 5 years. I got these photos yesterday. I asked her to send them in. So that was her pre-op on the left. You could see post-op, 5-year post-op. Not perfect, but pretty good compared to where she was before. So in summary, Boutonniere deformity seems like a simple problem, but it's not. Flexion is function, so we don't want to sacrifice flexion. Appearance, it's nice to have it straight. Patients like that, but if they lose flexion, they won't be happy. And it's best to restore passive extension before attempting tendon rebalancing. Thanks.
Thank you, Chuck. That's awesome. So one of the things that I've always found difficult with the splinting of a boutonniere, so it's an acute boutonniere, especially in the small finger, is just having failures with the patients wearing the splint or keeping it on, or they think it's on, but it's not holding, like that classic boutonniere splint where it's supposed to keep the PIP extended and allow DIP flexion. So this is a question for you, Dr. Cassidy, and even Brad Ernest can pipe in as therapist as well. But do you have any tips or tricks on how to improve the success for acute boutonnieres with the splinting protocol? It always seems to be frustrating for the patients.
Yeah. So I'll say that an aluminum splint that's limited to the finger doesn't work, because almost half of the proximal phalanx is proximal to the web, at least a third. So it tends to cantilever like this. It's very hard to control that. That having been said, I think you have to use a few splints because the skin can't tolerate a single splint all day long, all day and all night. Like that LMB splint is a great splint, but the patient's going to get skin problems over the proximal phalanx level from that pad. And so I like to use a combination of one of those splints or a static progressive splint, and then a thermoplast splint that the therapist makes that I think it's a little easier to control. It's more circumferential, so it's more uniform in terms of the contact. But I'd appreciate what Brad thinks about it.
Yeah, Dr. Cassidy, I agree with you in terms of having that custom thermoplastic splint, because we can get to those contours a lot better. I can go circumferential in the PIP joint or almost circumferential to really capture extension. I can have a dorsal hood portion of it if we want to put a little downward, flexion tilt of the DIP joint while we're putting the PIP in extension. So I have some options with the material. I can make it, more than your typical off-the-shelf splint. But I think those 3-point extension splints, what I call LMBs, can be appropriate for daytime use. But I find that at nighttime they slip, whereas I can custom make something that will stay in place. It doesn't slip. And then it requires just education of the patient, when to wear what splint, at what time, what's appropriate, and how to put it on appropriately. And I always have the patient put it on in front of me, so I know that they know how to put it on. I don't ever want to assume that I fit them with the splint and they understand. I will take it off of them, put it on the table, and then they are going to have to put it on themselves. And normally that takes a few sessions or a few reps for them to get that figured out.
Yeah, it's important to note that type of splint is a static splint, but there is still some stress relaxation that occurs. So I like a dynamic splint because it's exerting some force constantly. But serial casting works, and that's static, right? So you maximally extend it, and it's allowing over time the tissue to stretch out. And I think the same thing with that static splint, like what you describe, is that the patient should come back fairly regularly and have the splint modified as necessary.
Correct. Yes, we like to keep a close eye on them, and I agree. Boutonnieres, they might seem easy, but often they can be a challenging case.
Dr. Cassidy, you mentioned the digit widget. How do you decide? Is there factors that you would say this finger definitely needs the digit widget? Like, what's the line in the sand for you when you're thinking that they should have that?
Yeah. Well, virtually always I will try splinting first. And I think like what the two of you had talked about, buy-in from the patient to see what, because the story is not over when you do the surgery. They're going to need to splint afterwards too. So to see how committed they are to it. if they've had surgery in the past, I think it's really complicated, especially, and there's the biologic component that we had talked a little bit about, but patients respond differently to injury and they respond differently to surgery. And some patients do incredibly awesome and some patients get really stiff. And I like the digit widget because it's minimally invasive and gradually allows the tissues to straighten out without causing inflammation in general. I think if they're over aggressive, that can cause some inflammation. But so I like it. I like it if they're not making significant progress, if they have had prior surgery. One other point, though, is if they're much more than 90 degrees, it loses its mechanical advantage. So it's hard to get that extensor moment until you get to about 90. So you may want to choose a different method if it's really, really contracted. And those are bad. You know, this woman did great, thankfully, but I mean, great is like a B, right? I mean, to me, it's not perfect, but she's happy and I'm happy. Yeah. But you may think about just fusing it in a better position when it gets that bad, you know, shortening it and fusing it. And then no rehab is required.
I was going to ask you as well as Gilberto about the flexor tendon. Say it's a chronic flexor tendon and it's FDP only. And they're going to need 2 stages. So, Gilberto, you showed the bailout is the DIP screw, and that would be one philosophy is like, am I going to actually do a 2-stage reconstruction to get DIP flexion and restore FDP only in a finger that's otherwise supple, has normal FDS function? What are your thoughts, Gilberto, about a 2-stage? The worry I have is that some people will come back with a stiffer finger. Because they had 2 stages, all in the attempt to try to gain some DIP motion. What is your thoughts, Gilberto?
Well, definitely choosing the appropriate patient, find a patient that is motivated and it has the resources. You were mentioning before that in your state, sometimes it's hard to get patients to therapy. Here where I practice, sometimes it's the financial situation, but definitely you got to see the whole picture, making sure that your patient is the right candidate, it has the appropriate resources, and also I consider that we have one hand, but the 4 fingers, they are completely different. Your radial digits, they have some needs, and your ulnar digits, they have different needs. So if you are dealing with the ulnar digits of the hand, and your main goal is to get more DIP flexion because you need a proper grip, you want to make sure if taking your patient into the 3, 4, 5 months period of a 2-stage reconstruction is worth it. Or if your patient has other situation, like, for example, for some reason I have recently a lot of patients like ladies on her 50s, 60s, they have either lupus or other rheumatological condition, that the condition of the hand and the skin itself, that is not going to tolerate well a insertion of a rod and just hoping that the sheath is going to form. So that's why I consider that's an option that you got to have under your sleeve if it's needed.
Sure. And what do you think, Dr. Cassidy? Do you do DIP fusion for some patients that might otherwise need a 2-stage flexor reconstruction for FDP only?
So the question need, I would say, one point is if you're preparing for your boards wherever you are and that question gets brought up, don't buy it. Don't do a 2-stage reconstruction if the FDS is intact, except maybe in the small finger if it's really weak. That would be a good reason to do it. So that having been said, I do it on occasion. The ideal one to me is somebody it's fairly chronic and they have limited PIP motion because the tendon got hung up somewhere in the flexor tendon sheath and it's just caused some scarring. So their finger's not in great shape to begin with. Yeah. The harder one is if it's retracted into the palm and they actually have full PIP motion. And then you're wondering, do I really want to subject the patient to this? And sure. What the risks of 2-stage, as you mentioned, they're pretty high. I quote 30%. Somewhere along the way, they're going to have a problem 30% of the time. And the other part is, for me, it's a lot of these are kids like high school athletes, football players who sprain their finger and they don't want to tell anyone. They want to finish out the season, and their parents finally find out, and there's a lot of guilt involved, and their parents want to make sure the finger's fine. The kid just wants to get back to football. And, this is a month's investment. So the second stage can be deferred. I had a patient who developed breast cancer between the stages, and it was a year and a half before I did the second stage. As long as they have supple motion, they'll do fine.
Sure.
But I try not to, and I don't fuse them unless they're really unstable. I just let them be. Yeah.
We have one more question because we're about out of time, but one of the questions from the audience was, do you agree that you should leave boutonnieres with less than 30-degree of PIB lag alone? This is for Dr. Cassidy. And then the second half of that same person asked, do you use the Curtis staged reconstruction technique?
Well, so I kind of alluded to that in my talk. I sort of chopped it up into segments, but I think it's important to have the tools. So if you look at the Curtis stage protocol, the tools are there. You can see the components and you can choose, which or all of them to use. But the ideal to me, a supple boutonniere where DIP joint hyperextension predominates is a great candidate for an extensor tenotomy, and you're not going to mess up the finger.
Yeah.
When you start, messing with the central slip, that can be a problem. They could get really stiff, they could lose flexion, and they end up, if you look at the published results, aside from that recent article with the palmaris, the range of motion, like total arc, is 15 to 30 degrees. These boutonnieres do not do well in general with reconstructions.
Thank you.
Jay,
all right. Go ahead, Chai.
I wondered about single stage reconstruction in patients who have chronic profundus ruptures, but who maintain supple DIPs, who are young, their tissues are good. And in those patients, I have found that when you open them, the flexor sheath is contracted, no question, but it is good enough that it can take a palmaris, which can sneak through the most contracted flexor sheath. And you can do a single stage reconstruction. And if you need to dilate the flexor sheath, a trick I learned from Jim Strickland was to use pediatric urethral dilators.
Okay.
And I wondered, if any of the panel had anything to say about that.
Yeah, no, if sometimes you're right. That's why I say when I consent these patients, I always say end-to-end, single stage, two-stage, because you don't know what you're going to find. Sometimes the sheath is contracted, but the main, at least you have a sufficient A2 and A4, and you feel that the tendon can slide. And yeah, I use like a pediatric catheter, and I pass it, and sometimes you're able to open up. And then you pass your palmaris longus, and then you see that it glides. And as long as you can restore a good cascade and you don't have contractures, definitely that's a way better result than putting your patient through a second stage that has more unpredictable results.
Yes. And the thing that even if the flexor sheath is contracted over A4, the pediatric urethral dilators can just about create a little bit of creep intra-op, because they have this nice curve to them. And that creep is enough to get a nice tendon through. And the palmaris longus is invariably gracile enough that it won't interfere with the FDS function. So in general, I found that to be a very reasonable thing to do. But the number of patients you can do that is very small.
Yeah. I was going to emphasize that. And Chai, you're big with take-home messages, and that is it. It's very small, because usually that instance, there's something else going on. Why did the patient take so long to get here? What, are there any other injuries? And so you have to be careful. I've taken care of a bunch of patients who've had single-stage reconstructions that have failed, and they wasted a palmaris. And, that's a really difficult problem to salvage when it's been operated on a couple of times. Just one other tip, though, with the thumb, because we talked about FPL. So Urbanic published a technique on Z lengthening in the forearm for chronic FPL ruptures. So you can advance it all the way back as long as the sheath is fine, and lengthen it in the forearm. And I've also done that on the index finger in a couple of patients, because the index is fairly autonomous. And these were two medical people, believe it or not, who just neglected their FDP, and it was just hung up at around the PIP joint. And I was able to advance it. Like what you said, you could still get it underneath. That's bigger, though, than a palmaris. But and then liked it a little bit in the forum, then they did great. But that's the exception.
But all little tricks of the trade.
Yeah. I just want to say thank you to all of our faculty tonight. And I think we're going to finish on time. And we look forward to seeing you guys next week with Dr. Peter Reed for failure of soft tissue reconstruction. All right. Thank you, everyone.
Thanks, everyone.